Hello and welcome to Insider Ophthalmology Simplified. In today's video, we'll discuss regarding the treatment options, the recent advances in keratoconus. So, we had already discussed regarding the contact lens used in keratoconus. Now, we'll discuss the collagen cross-linking, the newer updates, the intracorneal ring segment, and keratoplasty. So coming to what is a progression of keratoconus? So it means there should be a consistent change in at least two of the following, that is either in the anterior corneal surface or the posterior corneal surface, or there should be a thinning of the cornea from periphery to the thinnest part of the cornea, right? So these are the indications that the keratoconus is progressing. So this progression can be documented by K1 and K2 values, which we will discuss further. Now coming to collagen cross-linking, so it is a bioengineering technique to increase the mechanical stability of cornea in corneal ectatic disorders, right? And it was actually first done in Dresden University in the 1990s on the animal eyes, the mechanism of action. So in the normal corneal stroma, there is collagen and there are bridges between the collagen. Whereas in keratoconus, this collagen is reduced and the bridges between them, that is the covalent bonds which are there, are distorted, making the cornea very thin. So what we employ in this corneal cross-linking is the riboflavin, that is vitamin B2, as well as UVA light. So the riboflavin is a vitamin, so it undergoes excitation and photoactivation under the influence of UVA light, which induces cross-linking of the collagen, and there is new covalent bond formation, thereby increasing the corneal rigidity. So coming to the rule, so it is used, the CXL is used in the progressive cases of keratoconus. So in this, if the Kmax is increased by 1 diopter or there is deterioration of visual acuity within 1 year of prescription of the contact lens or spectacles, or if the contact lens changes less than 2 years within 2 years of prescription. So these are the indicates it is a progressive disease. And this CXL is contraindicated in age less than 8 years, pregnancy and nursing mothers in when the corneal thickness is less than 300 to 350 microns, in case of severe ocular surface disorders wherein the surface is already very thin and dry eye is there, and in case of riboflavin allergy. So the technique employed is standard Dresden protocol. So as we said, it was first done by Dresden University. Right, so this is standard Dresden protocol. So the step 1 includes epithelial debridement. So the central 8 mm zone, or the zone which is the cone, is debrided, and in step 2 there is isotonic riboflavin is taken, that is 0.1% in 20% dextran T500. This is instilled in the cornea every 3 to 5 minutes for 30 minutes, and after that we employ UVA exposure. So this UVA is exposed for 30 minutes and the wavelength is 365 nanometer and the power is 3 milliwatt per centimeter square. So at the end we put a bandage contact lens and follow-up is done on day 1, day 4, day 7, then after that monthly for 3 months. That is first month, second month, third month, and after that 3 monthly for 1 year, that is at 6 months, 9 months and 1 year, and after 1 year it is done 6 monthly, right? So it is 1.5 years, 2 years, 2.5 years, like that. So this bandage contact lens which we keep at the end is removed usually by 4th day. So it's by this day the epithelium might have re-epithelialized, right? So that's why it's removed on the 4th day, and it is we employ moxifloxacin, that is antibiotic drops, fluoromethanol, and lubricant like carboxymethyl cellulose for the treatment for 1 week to 1 month. Now coming to the what are the newer techniques of CXL, we have accelerated CXL. So in this we use variable amounts of energy and the time period, but the total energy remains constant. So here we are applying riboflavin for 15 minutes followed by UVA, which is given for 9 minutes for 10 milliwatts per centimeter square. So here or 5 minutes into 18 milliwatt per centimeter square, or 15 minutes of 6 milliwatt per centimeter square. So as we observe here in the Dresden, the standard protocol, we had given riboflavin for 30 minutes and the UVA was given for 30 minutes and the power was 3 milliwatts per centimeter square. So here the total energy remains constant. So 30 into 3 is equal to 90, right? So this was the energy which is used in the Dresden. So in others also 9 into 10, 5 into 18, 15, 60 is the 90. So that means the total energy remains the same over here. So this is known as the accelerated CXL. So with this we are reducing the actual surgical time and the UVA exposure time, because UVA causes desiccation and discomfort to the patient, right? So this is regarding accelerated CXL. Then we have dextran free riboflavin. So it is, what happens is that while we are installing this riboflavin, there is a osmotic effect of the dextran, because of which the corneal thickness keeps on reducing. So instead of that, we will be using a 0.1% riboflavin in HPMC. So it will avoid the pachymetry reduction in the corneal thickness during the procedure. Okay, so this is dextran free riboflavin. Then we have pulsed CXL. So in this, the UVA it is given in 1 second on and 1 second off pulses. Okay, so it is reducing the exposure time. So in the same way that it will reduce the exposure of UVA and it will reduce the discomfort, right? So this is pulsed CXL, in which we give on and off UVA exposure. So as I forgot to mention, this is based on Bunsen-Roscoe law of photochemical reciprocal. Next, coming to hypoosmolar CXL. So in this 0.5% riboflavin with 0.9% the normal saline is used. So this is used if the corneal thickness is already little bit less, that is 350 to 400 microns. Next, coming to contact lens assisted CXL. So in this, the contact lens is loaded with riboflavin. So the BCL is used. So it is used to artificially increase the corneal thickness for the CXL procedure. Next one is customized debridement epithelial island CXL. So in this what we do is that only the energy is applied in the cone apex. So here the apex of the cone is intact, whereas the paracentral area around the cone, the epithelial is debrided. Okay. Then we have CXL plus procedures, that is CXL along with the PRK. Then we have CXL with thermal keratoplasty, or CXL along with Intacs, or CXL along with LASIK extra. So these are all CXL plus procedures. And just a note regarding PAC CXL. So this is a photoactivated chromophore for infective keratitis. So this is used in case of infective keratitis as an alternative to standard antibiotic therapy. In cases of infectious corneal keratitis, this can be used. We also have a customized CXL. So this is based upon the customized CXL is customized as per the patient's eyes and as per his variations in the K1, K2 values, and the energy is applied more in the cone and less energy is applied in the other areas. So something like that. So it is customized from the patient to patient. These were all the newer advances in the CXL. Then we have complications of this. So the most commonly encountered is corneal haze, which is seen in almost 90%, sterile infiltrates in 10%, and corneal edema. So these are the complications related to the CXL. Now coming to ICRS. So ICRS is intracorneal ring segments. So we will have a separate class regarding this. So the indications, the uses and all, this itself is a very vast topic. I'll just mention what are all the ICRS which are used in Keratoconus. So these are Intacs, Intacs SK, keraring and myoring, which can be used in cases of Keratoconus. So Intacs is a hexagonal, whereas Intacs SK is oval, and keraring and myoring are triangular. The arc length is 150 degrees is Intacs, and keraring is 90 to 210, myoring is a 360 degrees. So these are indicated when the patient is not happy or intolerant to the contact lens use, and also it should be used when there is no corneal scarring, right? So these are all the indications. Now coming to keratoplasty, this is reserved for very severe cases. So almost 12 to 20% of the advanced cases might require a keratoplasty. The procedure of choice is DALK, that is deep anterior lamellar keratoplasty. Whereas if the patient is having a central scar like that, then we need to go for a penetrating keratoplasty, and sometimes bowman membrane transplantation can also be done in some cases, but it is a surgically challenging procedure with minimal side effects of rejection. Just a note on the recent advances, that is CAIRS, it is corneal allogenic intrastromal ring segments, which was first done by Dr. Susan Jacob from Agarwal Eye Hospital, Chennai. Okay, so in this we are using the segments of the donor corneal tissues which are implanted into the cornea. Okay, so these are a variation of ICRS.